Okay, well, we'll go ahead and kick things off because we've got a lot to cover today. Welcome everybody. If you are wondering if you're in the right place, today we are talking about fulfilling requirements without forgetting humanity, practical strategies for person-centered care with Ariel Singer, which is Ariel and I have known each other for a while. We'll talk more about that, but I'm very excited for today's topic because I know a lot of agencies right now are involved in different quality improvement projects where you're doing more screenings, you're doing more kind of administrative-y things, and I love this opportunity to talk about how to make that whole process more person-centered. So thanks for joining us for this fun hour where we're going to talk about that. As I mentioned, I always like to know where you are in the world. If you could hop over to the chat and let us know where you are. And then we, for fun, said maybe today also let us know what the weather's like where you are. Nice to see people here from New York where it's either rainy or very cold. Beautiful and sunny in New York City, very cool, sunny in Wichita, cold and overcast in Minneapolis. It's in Portland, it's overcast or kind of sunny and very crispy weather today. That's where I am in the world. And this is a picture from where I was last week, which was in Sun River, Oregon, at an Oregon leadership conference where I got to give a talk. So nice to see everybody. We're glad that you're here. So just a few quick housekeeping things. We're recording today's session, so you can relax. And if you really like what we talked about today, you can share this recording with other people on your team to help them get familiar with this topic and help them think about it. You can ask questions as we go in the chat. Hopefully, sometimes we accidentally have the Q&A feature turned on in Zoom, and we're not great at remembering to look there. So if you want to make sure we answer your question, it'd be cool to put it in the chat because we do have several folks monitoring that. And then we'll email materials after the webinar. I think Ariel is willing to share her slides too. So we'll have slides we can send out after the webinar too. So if you see something cool, don't frantically try to copy it down. We will give you those as a handout too. So just real quickly, you're in the right place today if you are involved in something where you're collecting information from individuals who are receiving services. Maybe you are someone who completes screening tools, or maybe you support the staff who are doing screening tools, or maybe you design the workflows that are being used by people, or maybe you're just trying to improve metrics that rely on screening tools. Or maybe you just want to understand more about how screening tools can be implemented in a more person-centered way. So if you're like a data person, but you are just kind of curious about this, or maybe you're trying to talk to your clinicians and you'd like more shared language, I think today is also a good place to get that. So quick introductions. If you don't already know me, I'm Ginger Bandeen. I'm the founder and CEO at Mission Driven Data. I'm a social worker, and now I have this company where we try to help agencies think about how they use their data. But what I love about today's topic is it's more about how you collect your data. And so I'm really excited about that. And today we are joined by an amazing guest speaker, Ariel Singer, who is the founder of Waterwheel Health Consulting. Ariel is a human-centered healthcare educator, change facilitator, advocate. I run across her work all the time because I'm always hunting down cool ideas, and Ariel seems to be involved in a lot of cool ideas that are happening out there. She was involved in a rapid engagement project in Oregon. I think that was maybe how I first ran across her work, but also an expert on motivational interviewing and system transformation. And she's partnered with a lot of organizations around the country. We also ran into each other at the National Council Conference last year, where I believe Ariel had a poster presentation. So lots of cool things. You should be following her on LinkedIn and getting to know Ariel because she's really great. Just a quick reminder about what Mission Driven Data is. We have data tools to help agencies get data out of their EHR. We have a community. If you're not already a member of our community, you should join, because then you'll hear about cool things like this. And then we do consulting. So real quick, we just wanted to get some information from you guys. So hold on, and I'm going to do a quick poll. Here we go. So we would love to know just a little bit about who else here today, besides where you are and what the weather's like, because I always love where you are and what the weather's like. But it would be fun to know how many folks here would describe yourselves as a clinician, a care coordinator, or case manager. a program or clinical supervisor, administrator or leadership, data quality evaluation, or something else. And then the second question is, oh gosh, I made 4 questions, so it's okay if it's taking you a second to read through these. So my next question is, how involved are you with the screening tools used at your agency? Are you a person who completes the screenings? Do you supervise the people? Do you develop the workflows? Like, which of these things is you? And I think you can mark more than one on there. And then I was really curious about this question, and I just decided to ask it. Over the last 3 years, would you say the number of screening tools your agency uses has increased a lot, a little, stayed the same, decreased a little, or a lot? Because I thought that would be fun to know. And then how familiar are you with the idea of applying a person-centered approach to screening? So I'm going to give everybody a second because that was a lot of questions, but I was really excited to have a chance to ask you guys some of these things, partly for today's conversation, but also it's always good to know who's coming to our webinars and how we can create better things for you guys. So thanks for taking a minute to answer the poll. I'm going to give everybody a minute to get your answers in. While you're answering that, I was just going to do a quick mention that we have another webinar next week. So if you haven't already heard about that, you're going to be hearing about that soon. So, okay. I'm going to give people one more minute because it looks like there's still a couple of people filling things out. But just to kind of summarize where we're at, it looks like there's quite a few people here from administrative or leadership roles and data quality and evaluation roles, a few people who are program or clinical supervisors, and a few clinician folks. And then as far as how involved you are with screening tools, most people are saying they're looking at the results of screenings. Some people are developing workflows for screenings. Some people are completing the screenings. And then there's a couple of supervisors or folks doing something else. And then looks like right now, out of everyone who's voted, increased a little and stayed the same are the highest votes, and increased a lot is also had some votes. Decreased did not get any votes. No one's doing fewer screenings. And then as far as how familiar you are with applying a person-centered approach to screening, there's some folks who are saying they're very familiar, and then some people somewhat and not very. So yeah, thanks everybody for filling this out. It's super helpful to know who's here, and I'm going to go ahead and end the poll, and then I'm going to stop sharing my screen, and Ariel is going to share her screen. So thanks, Ariel.
Thank you, Ginger, for the opportunity to share some ideas with your community and to talk about one of my favorite topics, person-centered care. So I'll start by sharing just a little bit more about how I got here and how I came to be so focused on person-centered screening and screening as a function in clinical settings. So I started my career working at the Oregon Health and Science University, like Ginger. I'm based in Portland. And I was a health coach where I got really excellent on the job training and clinical supervision and motivational interviewing to follow up with people about their screening results from either a biometric screening that they did with our program or a health risk assessment survey. And so I got like just a lot of really direct experience having person-centered conversations about screening results. And then I went on after that was 15 years ago since I have left that job as a health coach and have gone on to work primarily on system change, first at the and within that context worked on a lot of different screening implementation efforts. So working on SBIRT, substance use disorder screening, and a follow-up in various healthcare settings with the Addiction Technology Transfer Center. I spent many years working at the Oregon Primary Care Association with all of the community health centers here in Oregon, and did a lot of work on, in particular, social needs screening and promotion of a person-centered approach to social needs screening in that context. Between 2021 and 2024, I worked with the Kaiser Permanente Washington Health Research Institute as the practice facilitator supporting implementation of social needs screening in primary care and 2 clinics within KP Washington, and also led our qualitative evaluation of that initiative, which I'm going to share some of our results from that study with you in this presentation. And have been working, although I do work a lot in the area of person-centered screening and social health integration. I also work more broadly with under this umbrella of Waterwheel Health Consulting on different kinds of system transformation initiatives, mostly in community health settings, whether community health centers or community mental health. And I also do a variety of different things relating to health communication, both this kind of person-centered screening work, as well as motivational interviewing and developing health communication materials. And I also collaborate with research teams in various ways on health promotion and health services research. So that very direct personal experience conducting screening conversations, and then all of this work on various kind of system level initiatives to implement and improve screening have really informed my thinking about what does really high quality screening and follow-up look like in clinical settings. So I want to start by telling you a story about an experience I had over the summer where I was leading a workshop on person-centered screening and system design for person-centered screening. And one of the attendees at this workshop told me that his agency is striving to adopt the platinum rule in how they deliver their services. And what he described as the platinum rule, which this was public, there was like a business pop kind of business book that was published a few years ago about the platinum rule. And I think that has been a big source of dissemination for this idea, which is not that we should treat people how we would like to be treated, which is one of the primary formulations of the golden rule, but that we should treat people how they would like to be treated. Now, of course, I think this sounds like a great idea, and I certainly would love for us to be able to meet every person where they are and treat them how they would like to be treated. But my belief is that in a busy healthcare setting, that is not very functional, because we cannot find out from every person in advance how they would like to be treated before we begin interacting with them. And we have a really high volume of throughput, lots of different people coming in seeking services, lots of different people delivering services. I just don't think this is practical. So thankfully, I think that we can very reliably fall back onto the golden rule, which is a very ancient idea for thinking about how we can shape our conduct and our behavior in different settings. And I particularly like the formulation of the golden rule. It's shows up in many different cultures, can be described in different ways. You commonly hear it as treat other people how you would like to be treated. Hillel the Elder, an ancient sage, formulated it in the negative. What is hateful to you, do not do to your fellow. And I think that is a very helpful way to think about it in the context of health system design. Because if all we do is avoid doing things to people that create psychological distress or discomfort to them, then we will have a much better starting point for a effective relationship. So there certainly are a bunch of positive things that we can do, a person-centered behaviors and skills we can introduce into our interactions. But if we could at least start by avoiding doing things that are bothersome to people, we will be in a better place. So another way to think about the value of person-centered care is with respect to universal precaution or universal design. So our goal, I think, in healthcare settings should be at a minimum to create an experience for people where they can have a consistent psychological safety so that they are disarmed and open enough to be able to engage effectively in health services. And there's a lot of different reasons why people might come into healthcare environments already feeling very guarded, or additional things that happen in the context of their interactions with the healthcare team or with the clinical environment that make them feel even more guarded, which is the opposite of what we want. And of course, when we're having healthcare interactions with people, we're often talking to them about very sensitive, intimate, and tender things. And in particular, in the context of offering whole person care and trying to ask people not just about their health experiences, but their life overall, all kinds of things can come up first of all, we ask them all kinds of questions, and we just don't know how those questions are going to land with them or what their answers might consist of or how it might feel to them to either be asked or to give a truthful answer. So it is unpredictable. So I think a good analogy that we can use to think about person-centered care is a seatbelt. So every time we get into a car, we know there's the risk of an accident. We don't know if there's might be a crash on that particular drive. So we wear our seatbelt. We're encouraged to wear our seatbelt as a universal precaution every single time, whether you need it on that drive or not. Similarly, I think we should apply person-centered care as a universal precaution in healthcare interactions, and to really think about how we can use trauma informed and person centered practices to promote engagement and safety for everyone. Maybe ultimately, once we get to know people, we can tailor the way we offer care to them using the platinum rule. But as a starting point, I really think that person centered care gives us a way to enact the golden rule and to just try to create like environment that can create basic safety for everybody. So these are big ideas. Person-centered care is a style of practice and it's aspirational, to even have the golden rule, let alone the platinum rule, but to even have the golden rule in a busy and highly regulated and complex healthcare environment is aspirational. And for us to be able to take it from a really cool and compelling idea that we can get behind from a kind of moral and emotional standpoint to having it be something that we're doing on a day-to-day basis in our practice setting, I think we really have to think about how can we translate from this big idea, a style of practice, into specific attitudes and behaviors that we are embedding into our routine clinical processes. And today, what we're going to talk about is what might it look like to take this idea of person-centered care and apply it specifically just to screening, which is just one clinical function of many, but is one in which we are asking people a lot of intimate questions and potentially highly stigmatized and fraught questions. And so there's a big opportunity here to use person-centered care to create more safety and engagement for people. So, in order to share ideas about good attitudes, good and effective attitudes and behaviors for the routine clinical process of screening, I have developed a guidance framework called collaborative screening. That's a way to make our routine screenings more meaningful. And it's really a quality improvement framework that includes strategies and skills for creating respectful conversations, as well as creating systems and interactions that can promote equity by creating safety and trustworthiness for everyone. Hopefully, if we're doing person-centered care consistently, we don't need to make special accommodations for the people who are more hesitant to disclose what's going on with with their life, because we're really approaching everyone with respect, and with precautions in place to communicate to them that we are safe to talk to. The other thing about collaborative screening that I think is really important to remember is that for many areas of need, whether that's in the context of social health screening and people disclosing social challenges that they're having, or in behavioral health issues, services that they need, even medical issues and services that they need, those resources, those supports, those services, they are not always available. And of course, it would be better if every time someone screamed positive, we could follow up with some kind of material assistance, whether it's a clinical service or a social service. But unfortunately, we often cannot. And a supportive conversation may be all that we can offer. And what we can see from the research is that actually supportive conversations can make a difference for people, and it should not be underestimated what value there is to having that moment of human connection and having someone feel heard, offering them empathy in response to whatever they're going through. So, how do we know that supportive conversations make a difference? I'm going to share a little bit more information with you from research on social health integration. And I think that this uh, there's there's research into other types of screening, and there's a lot of, I think, corollaries we can draw between social health and other kinds, talking to people about other sensitive topics. But for the purposes of today's conversation, we're really going to focus on social health screening as an implementation issue. So we're in this environment over the past 10 years, especially where the awareness about the impact of social needs on health has been growing. The imperatives to conduct social health screening have been growing. And the question that we have to ask ourselves is, well, how does screening help with those issues? Even if we know that social needs have a big impact on health, how does talking to people about them in clinical settings make a difference? So this is, I'm going to share with you a logic model from an article that was published by Laura Gottlieb and her colleagues at the Social Interventions Research and Evaluation Network, SIREN, at UCSF. This is in this group of researchers, and Laura Gottlieb as a researcher are really some of the leading folks in the country looking at these issues. This is an open access article, so if you're interested in reading this, you can go to the Milbank Quarterly and find this article, but I'm going to summarize it for you now. So the initial idea for how social health screening could help people in healthcare settings, and the way that they're defining like a positive outcome is, um, and you'll see this across all elements of this logic model, is that the goal is to improve health and decrease avoidable healthcare utilization. So the initial idea behind this type of screening is that we could screen and identify unmet social risks. Patients could get connected to social services that would decrease their social risk, and then that would improve their health and decrease avoidable healthcare utilization. But after many years of doing implementation and research on real world experiences with this pathway, the picture starts to look more complex, that perhaps there are additional possibilities for how social screening could help people in a healthcare setting. So one additional possibility is through emotional support or healing relationships. That just by connecting people with a social service navigator, even when they don't get any services, that experience with the navigator, that emotional support, that can itself improve health and decrease avoidable healthcare utilization. Another possibility is that by conducting screening, we're able to better understand what kind of outpatient healthcare services people need that are not being met, improve their utilization of those services, and again, thereby improve health and decrease avoidable healthcare utilization. And the last pathway that Gottlieb and her colleagues put forward in this article, based on their review of the research, is that we can also, based on screening results, tailor the care plan and adjust how clinical care is provided, doing a more effective job of meeting people where they're at in their social circumstances, and taking a whole person approach, thereby improving disease self-management, ultimately improving health and decreasing avoidable healthcare utilization. So they published this logic model last year saying, we've looked at all of this research. Here, it seems like here are some additional possibilities for how we could be helping people with social needs screening. And there's more research to be done in terms of specifically how can we help people in these different ways and what is practical in real world settings. So as I mentioned, I worked on this project with Kaiser Permanente and Washington to implement social needs screening. And we then interviewed 50 patients who had participated in this social screening program. And I worked on this project as a team member at the ACT Center, the Center for Accelerating Care Transformation, that does a lot of work on primary care and safety net healthcare transformation. And as part of this research team, we had folks who screened positive for any of for wanting assistance with any of the items that you can see here. This is a little excerpt, what's circled in red, from our screening tool. And then patients were randomized to either speak with a local community resource specialist or to receive outreach from a centralized Kaiser Permanente call center. And then we conducted a mixed methods evaluation, looking at changes in outcomes and cost, and then also conducted this interview series with patients who had participated in this process. So I'm not going to report on the quantitative results here, but I'll talk a little bit about what we heard from patients from doing this interview series. Okay, so what we did was we took our results and we organized, we did our analysis looking at themes of what we heard from the patients, and then we organized them using this logic model that Gottlieb and colleagues just published. And what we saw with respect to reducing the burden of social risks as a pathway for helping people is that it simply rarely happened in our sample. And this may not be surprising to you if you have done any work in terms of social services, that there's not enough of them. They often don't exist in many communities, especially like in a smaller or more rural community, or even in urban communities where there are more social services potentially. There are many people who have social needs who are not eligible. There's often very Byzantine and complex eligibility requirements, hoops that people have to jump through. And it can be just quite difficult to actually go from screening all the way to getting that material need met. The most surprising finding from this series of interviews was that despite the fact that we had many patients who did not receive any resources, and we asked them that question, like, did you get connected to resources from participating in this program? Then we also asked them the question of, do you feel that your needs were met? And many more people said yes to that question than had actually received any resources or services to meet their material needs. So that was a quite surprising finding to us, that many people felt like this was useful and valuable to them and had met a need in some way, even if it was not a material need. With respect to healthcare services and connections to healthcare services, we found that that didn't really happen in this context. And in fact, I mean, it happened to some, but many patients seemed actually concerned about even just getting their basic healthcare needs met in primary care. There's just not enough capacity to give people the kind of time and support that they might want. And that's a challenge not just in primary care, but really in any clinical delivery setting these days, whether it's a hospital or a behavioral health clinic. There's just many, many competing priorities and demands on the workforce. So people often might feel like they don't quite have as much time with their clinician as they would like. And then with respect to tailoring clinical care in response to people's screening results, we found that that seemed to also rarely happen. And I think that's because it's operationally and clinically complex to administer a screening and then in real time have those results be available to the clinician, have them look at them, review them, and think about how to adapt care based on that new information. So what we found was that this seemed like the strongest pathway, this emotional support healing relationships pathway, in terms of how frequently the patients seemed to feel that this pathway was being met in their experience, and how surprisingly meaningful that was to them. So if you're interested in hearing more about this research, learning more about what we found across all of these pathways, we have this article that was just published last week. It's an open access article as well. So if you're interested in learning more, you can find this article online, and anybody can read it without a paywall. So I will be honest in saying that I already had a really strong commitment and bias towards the value of emotional support and healing relationships in healthcare settings. And doing this research really confirmed for me that this is a useful and available intervention that we can offer people that can be meaningful to them, to have a good conversation, even when we can't do anything else and we can't do all of those other complex things about connecting them to other services or resources or trying to like really change how their care is being delivered. We can offer them a good conversation and it can make a difference. So, my belief is that to move in the direction of offering people a person centered experience with screening and follow up conversations of any kind, that we have to be operating at the level of both what we do with people, but how we think about the value of what we're providing and what our role is in that process. So I think that once we start to recognize that having a good conversation can actually make a really big difference, and we can be really intentional about cultivating the mindsets. Um, to have a good conversation, then we can also be really purposeful about translating that mindset into our communication behaviors. And it becomes this self reinforcing loop that gets enacted in our relationships. It's an internal experience and an interpersonal experience. So I do see, Rebecca, your question in the chat about how I would define a supportive conversation. And that is now what I'm going to talk about. What from the standpoint of screening, what I think goes into a good conversation. And the way I'm going to frame this is in terms of, let's say all we can do is like that basic level of universal precaution. How can we enact the golden rule and do our best to offer people a non-harming relationship? Or sorry, non-harming conversation about really intimate aspects of their lives that they might have some shame around. And then I'll build from there into adding in ideas from different approaches to person-centered care, for how to go deeper and to how go from non-harming to really providing people with emotional support. So I want to introduce you to a tool that I have developed as part of the collaborative screening toolkit. And this is available on my website, and I'll put the link in the chat in a minute. When I take a pause from talking, and we can have some Q&A, and I can give you the link there so you can go look at this yourself. But this is it's a suggestion for how you might navigate these conversations from open to close. How can we go through this process of getting into a deep exploratory conversation with people and then getting to a set of concrete next steps within a brief interaction in a clinical setting? And the diamond is intended to communicate something about the shape of our conversation or the nature of our conversation, that we're starting often from zero with somebody in terms of maybe you've never met them before. And you're trying to go from just the establishing a relationship to having this meaningful conversation and then closing out in a really specific way within a short period of time. So, in terms of the basic workflow, if you don't have the staff to do extensive follow up conversations, you don't have a lot of resources to put towards whatever this screening enterprise is in your clinic, I think this is what a basic version looks like. And as I said, I've been talking about this in the context of social health screening today. But I really think this applies if you're asking people about tobacco use, if you're asking people about drugs and alcohol, if you're asking them about medication compliance. There's just all kinds of things that we're asking people these questions that actually could feel really delicate to them. And I think, and one other thing I'll mention in terms of how I put this together. So this is drawing extensively from the practices of motivational interviewing, trauma-informed care, cultural humility, health literacy, really try, and then also looking at a whole bunch of implementation research and qualitative research on patient experience with different kinds of screenings. And there's very, very, very consistent findings on what patients have to say about what is important to them in the screening process. So if you really don't have very much time, I think one of the most important things we can do with respect to enhancing a trauma-informed approach is to give people more information up front, to give them a better explanation that often gets overlooked. So we always want to start with a good opening with respect to saying, here is what you should expect from us. That will make a very big difference in promoting psychological safety. Then we have to inquire, and ideally, we will have already seen their responses. I am a proponent of self-administering of screening rather than conducting screening as an interview because that puts people on the spot, and instead to have them do it themselves and then have a follow-up conversation. So if you have done self-administration, you can start by just acknowledging that you have seen their responses or asking permission. If you're doing it as an interview, is it okay if I ask you some questions? Or even if you're presenting the form, would you mind filling this out? And so that's kind of like the basic starting point is acknowledgement. And what's really interesting is how often, and you think about your own experience as a patient, how often you have gone through some kind of clinical process in a healthcare setting and no one has ever said anything to you about it in follow-up. And that is something that I've heard about from patients in focus groups and talking to them about their experience, that it feels bad to disclose personal information, to be asked to jump through various clinical hoops and not have anybody say anything to you about it in follow up. So if we don't have very much time, we really can't do all of that exploring and partnership with patients, but we want to provide some information. Here are some resources you can try. Here are some options at a basic level. Again, having something in response to just acknowledge to them that they answered our question and we heard what they say. At the end of the day, I would say, Rebecca, to answer your question about what makes for a supportive conversation, I think you could really boil it down to whether someone feels heard on a very basic level. Did we communicate to them that we heard their responses to our questions, and that they have been acknowledged at that level of being listened to? Then I think it's quite important to also tell people what to expect next. So perhaps it's just, I'm putting this information in your chart, in your discharge summary. If you're not able to offer additional services, that's a good starting point. And then thanks for sharing this with us. So on the next slide, I have some more details about, again, if you look at the literature on what people have to say about this, here's what I think is quite important into that, going into that strong opening and how you can script that with either these kinds of key points or an actual like really well described script to give to your staff. So this first bullet corresponds with people not wanting to be singled out. So we have some new questions we're asking everyone, not like, oh, you look like you should fill out our social needs screener, or you really look like you should answer our drug and alcohol questionnaire, right? We want to avoid people having that experience. Then we also want to give people an explanation as to why we are asking. Our goal is to see if we can help with any issues in your life that may be affecting your health. Then we also need to set appropriate expectations with people. We may not be able to help with everything, but we'll do our best because people, they really don't know why we're asking these questions, what we're doing with this information. They're concerned about their privacy, what is maybe the real fallout to them of sharing this kind of information. Another patient in a focus group that I ran said, like, these are the same questions that I have to answer on an application for social services. And it's not necessarily clear to me that this is just a screening and not an application, and that there's not necessarily going to be any support that comes after. So, again, with thinking about psychological safety, we want to make sure that people know what to expect at every step of the way, because being surprised, in this context can feel really destabilizing. So then there's a lot of privacy concerns. So letting people know that your responses are confidential as part of your medical record. And then as another aspect of trauma-informed practice, just acknowledging that, again, with transparency, some of these questions may feel kind of sensitive, and then supporting their autonomy. You're not required to answer. And, please let me know if you have any questions as you start filling it out. So these are the kinds of really specific points that will help people from the very beginning feel like your organization is trustworthy to disclose information to. Okay, now, so let's say you have a little bit more time and you can go a bit deeper with people in your follow-up to their screening results. Is, of course, again, we want to start with the same strong opening. Here's how we work with people and what to expect. Now, when we inquire, we want to move from just saying, I see your questionnaire responses, or would you fill out this form for me, to asking some open questions. Would you be willing to tell me more about what's going on in your life, and to actually give them a chance to talk, and so that we can have the chance to be a good listener and to show them that we see them as more as a checklist, as more than a checklist. They're not just a screening form. They have a whole story to tell us behind whatever goes onto that screening form. Then we want to create a focus, because it may be that people have a bunch of different stuff that comes up either on their form or when you talk to a community resource specialist. This is something I heard from the folks at KP Washington quite a bit, is there's what they put on the screening form, but then when you start talking to them, there's all the other stuff that comes out in the conversation. So really trying to get clear about what is their top priority, not what do I think their top priority should be, but what is their top priority. And then some exploration that's rooted in partnership. Here are some resources you could try, here's some ideas, but I'm not going to make an assumption that that's what you want. So making sure to have it be a dialogue. What sounds good to you? What would work for you? Again, letting them know what to expect. I'll put this information in your chart and in your discharge summary so they know what's going to happen. And again, thanks for sharing with us. Now, if you have the staff, maybe you have a community health worker, a peer support specialist, a care coordinator, a care manager, some kind of person who has the time to go deeper with someone and following up on their screening results. Then we can go deeper with how we follow up with people and also what conversation skills we're using in that process. So what I'm going to share with you now is the most in-depth version, and then a snapshot of kind of what goes into it. And I want to make sure we have some time for questions. So I'm going to try to keep this brief and wrap up, so we can have some Q&A. And then, as I mentioned, like this information is in the conversation map on the website. And if you're interested in more details, you can take a look at it there. And then also feel free to reach out to me. Okay, so if we have more time and more personnel, of course, we still want to open with the same strong, here's how we work with people and what to expect. Again, we want to inquire using open questions. Go from this is a checklist of multiple choice options to you are a whole person with a story to tell. And then with focusing, maybe we can go into a deeper mode of exploration, not just what is your top priority, but what are your goals and your priorities overall. Maybe we can address several things. Maybe we can look at how your priority right now today fits into your overall health goals for your life, or what you're trying to work towards more broadly. Then we can also, again, explore, offer support in a way that's rooted in partnership and avoids making assumptions, not just here are some ways that we can provide support, but then what sounds good to you? What would you like? Let's talk together about it. Then, if you have time, I think a really small and powerful thing that we can do to shift from the deficit focus and deficit nature of screening to really having a strengths-based conversation is to also ask people, what do you enjoy, or what do you care about? What or who matters to you? This can be part of a conversation that embraces cultural humility, finding out about what is going on in someone's life around them, what community they're a part of, what their background is, what matters to them is a fundamental question that often doesn't get asked in healthcare settings and is certainly not built into our screening forms. So this is a way that we can, when we say we're offering whole person care, actually really do that, like bring the whole person and their strengths and their context into the conversation, and not say it's whole person, but actually it's only problem focused. And then you can also ideally have some kind of ongoing support for that person and follow up with them over time, see how they're doing. If all you can do is like a really brief intervention, that can be valuable. And there's also people for whom, even if you give them resources, they're going to need ongoing support to make use of them. And then lastly, if you have the time and you can go deeper, and I think this is something that like you could consider doing with less time, but just given the nature of how I have this set up, I've put it here, is to use the health literacy practice of teach back, to make sure that people are walking away with a clear understanding of the information that you've shared with them and what their options are. So I'm just going to offer two different kind of like summary snapshots of this information. So one is, again, this is from the conversation map on the website, a more detailed diagram with that diamond shape showing these different key steps in a good screening conversation, and then offering some suggestions for what are the specific communication behaviors that you might use in those different steps, in order to effectively open the conversation, to effectively inquire or set a focus, to explore what's going on for people, and to create a good plan and closure. Then, organized by a kind of method, um, I have a different way of summarizing the key communication skills that are embedded on that map and how we're pulling from trauma-informed care by providing people with clear explanations, respecting their privacy and autonomy, not making assumptions about them. From motivational interviewing, we're using skills of asking open questions, providing strengths-based affirmations, using reflections to communicate empathy, using summaries to acknowledge the complexity and fullness of their experience, and using ask, offer, ask to share information. From cultural humility, we might ask about culture, values, and identity, asking who's important to them in their life or asking what matters to you. And from health literacy, trying to use plain language that people can understand what we're talking about. And then also, again, using teach back at the end to say, can you share back with me in your own words what we've discussed so I know that I was clear. So this is a lot of different ideas that I have thrown at you about how we can take a screening process and either do it efficiently, tightly, but well in a person-centered style. And then also, if you have more time and the staffing, how you can really go way deeper and have really offer people kind of an experience of therapeutic support, um, just around their screening results. And it does not have to be provided by a therapist. I am not a therapist. My background is in public health. And part of what I want to promote, the idea to people with all of this, is that you can use therapeutic communication skills and offer meaningful support to people, no matter what your background is. Anybody can learn these skills. Now, of course, this is a lot, and you don't have to do all of it to be doing something to promote person-centered care. And I really believe that when we think about person-centered care, we should see it as like a menu of a lot of different options, and we can think about like, well, what seems most at hand or available to me, what's under my control, what can I do without any additional resources, and just find one place to begin, one small practice to add, and that will take us down the road, on that journey of creating a person-centered approach. So I want to pause and see if there's any additional questions from the chat, or that you want to add to the chat now, or any questions that you want to ask Ginger, and take a few minutes for conversation before we have to end our time together.
Thanks, Ariel. This is so cool. I just feel like there's so many little threads here that you could follow. But one of the things I was thinking about when you were talking about the golden rule and the platinum rule was how the unique thing about what a lot of us are doing is that we are unless we never ever go to see our primary care doctor, we've all gone to the doctor and also been the person being screened with these screening tools. And so we know what that experience has been like for us. And so in a way, we do have some like firsthand knowledge of how we could improve that experience for the folks where we're doing that. And I'm sure all of you listening have been to the doctor's office and had them hand you a bunch of forms with no explanation. And you know why they're doing that, because you're like, oh yeah, this is a HEDIS measure and this is a whatever. But like knowing that they're doing that with everyone, like you don't wear a badge that says I'm a mental health worker, so I understand your
Right.
HEDIS measures. So I think that explanation up front thing is so cool. And then yeah, I think all of that just I love this idea that if you just see that the point of doing the screening isn't to get the result, isn't just the result of the screening as much as it is how you interact with a person about their screening, and that that actually has the possibility of helping them at least as much, if not more, than actually doing the screening itself. And I think we often think of screenings as like checking a box and not like having that interaction. And you're going to do it anyway. So you might as well make it more meaningful for both. I feel like that would also would you agree, Ariel, that that would also make it more fulfilling for the staff person who's doing the screening too? Like it's an interaction that goes both ways a little bit.
I think so, both in terms of, I think people come to work in healthcare because they want to help people and they want to connect with people, and having even a brief, meaningful interaction is can be fulfilling and feel nourishing. But it also, I think, can be less draining to feel really prepared to go into a conversation in a way that you're really supporting someone else's autonomy, and like you know that you are asking them to do something that might feel hard to them, but that you're asking them in such a way that is feels respectful and rooted in integrity and interpersonal connection, even if it's just at the level of giving them a clear explanation and letting them know that it's their choice whether or not to fill it out, and letting them know what to expect, even if you're not having some super in-depth follow-up conversation. I think that that is going to produce better interactions. Like you yourself can have more confidence in how you're approaching it, and you're also less likely to have people get mad about the
Right.
questions that you're asking them.
Yeah.
And also to feel more prepared to respond if they do, with autonomy, support, and an acknowledgement that it's their choice. Yeah,
Yeah.
so I think this helps. I think this kind of approach can make a really big difference on the patient side of things. And then, as you're suggesting, also on the workforce side of things. And there is, again, in the area at least of social screening, quite a bit of research about that and burnout for the workforce, and a recognition that providing more organizational support and like a robustness to how we implement things reduces the risk of burnout. Because otherwise, we're just like asking um, an already overburdened workforce to just like do more and take on more and ask people hard questions. And the more that I think, can approach that with a sense of our own clarity and integrity and confidence about how we're doing it, the more sustainable it feels.
Yeah. That makes a lot of sense. Well, I would like to do our final poll, I think, and give people a chance. But if you have questions, please do feel free to put them in the chat because we still have a few minutes here. So, and then Ariel is sharing her slide that has some information. We'll also send out handouts after this. I'm going to go ahead and share my screen with our poll questions and launch our poll, because I would love, I think, kind of almost, oops, hold on, let me see here. Um, okay, so kind of in line with actually, oh look, there's a thing in the chat. This is great. While you guys are filling out this poll, let me look at this question really quick, or comment. Oh yeah, this is a comment from someone who does, from Jacqueline, who works with kids K through 12, and just talking about using all these screening tools and thanking them for sharing the information, being supportive in their space and conversation. I
I
see
also
your
appreciate
responses.
you
Yeah, go
in
ahead.
that chat comment, just again mentioning other kinds of screening questionnaires. Like I said, I was talking today a lot about social health screening, but I think all of this stuff is so relevant across so many different kinds of screenings, because a lot of it feels kind of sensitive for people to talk about. Even something like the GAD-7 or PHQ-9, I'm not familiar with what CSSRS is, but that, especially for young people, like it can be hard to talk about
Mhm.
those things. And the way that we do it and that basic like acknowledgement and curiosity can make a big difference.
Yeah, I'm guessing CSSRS is Columbia Suicide Screening,
Yeah. Okay,
maybe.
that makes sense.
Yeah, which is
Yeah,
definitely sensitive questions.
for sure.
Yeah, and even the PHQ-9. I mean, I think we do the PHQ-9 so often in mental health with the HEDIS measures we're required to do that we forget that those are like personal questions we're asking someone, and that people might feel self-conscious about sharing that, um, and and also we ask those questions a lot sometimes. Like we ask it like
Mhm.
every session, and helping people have some understanding of what we're doing or why we're doing it that way. Um, Even just giving people some language or some ideas of what to say if they work at the front desk and they're handing out the same form, like giving them some language around like why that's important or what it has to do with someone's health or, yeah, I mean, and I think also and Ariel and I talked about this a little bit when we were preparing for today, but just about how it's also okay to sometimes use our clinical judgment and decide that it's not the right time to ask screening questions. And I think sometimes we're so committed to getting good scores on HEDIS measures and stuff like that, that we forget that like, if you're meeting with someone who's in memory care, maybe you don't expect them to fill out a PHQ-9 because maybe that is kind of silly, and like maybe it's not really doing anyone any good to have their caregiver sitting there filling it out for them when like the person is maybe not super verbal anymore. So just thinking about that, I think sometimes we feel a little bit stuck having to do things because that's the metric we're trying to meet. And that also can lead, I think, to some feelings of burnout, like in the staff. Like, we know this
Mhm.
is silly. Why are we doing this? And we're still doing it. So,
Yeah.
um,
Yeah, the forces driving system behavior are so powerful. Um, and I think that one of the things that I find valuable about talking about the person-centered approach so explicitly is to just like remind everyone that that's an option, that we do have to do things that are in accordance with the system, but we can balance them by also thinking about our own experience as humans and the experience of the people that we're trying to serve.
yeah, it's sort of a way of like remembering our agency, like our own
Mhm.
like sense of what we have control over. Well, thanks everybody for
Absolutely.
filling out the poll. It definitely looks like people appreciated a chance to reflect on their current practices and how they might improve. And also people mentioned, thinking about the importance of supportive interactions and thinking about collaborative screening methods. And then there are some short answers that we'll review after too. So thanks you guys. There's also a note in the chat about this reminding Rebecca of the research that shows that a good relationship with the therapist gets as much success as like empirically based interventions, which I totally am aware of too and think is probably true. Okay, so I know we're close to running out of time. I just wanted to remind everybody that we have our free community that you're all very welcome to join. Bunch of stuff that I wanted to say, like if you are in a state and you would like us to host a user group, that's one of the things we do for people in our community. Wanted to bring your attention to an upcoming event, which might be a slightly different audience than the folks here today, but we're talking about financial dashboards next week with Catherine Kennedy from Morrison Child and Family Services. Also an important part of keeping everybody going in these dark times. So in our community, we also have co-working coming up in the next couple of months. If you are interested in presenting, you're always welcome to email us. The email that you would reach out to would be kdp@missiondrivendata.com. Um, and then I just wanted to give you guys my contact information. We'll send out a handout after today's session. We would love to have you join our free community. Ariel, thank you so much for sharing your knowledge with us. I'm going to stop sharing my screen for a minute. I just think this is such a great topic, and I think it's so good to have minutes where we all pause and like regroup and think about, some of the stuff we learned, like maybe in school, but also not all of us, went to social work school. So
Including
like,
me.
Yeah. So just having a chance to have some exposure to these ideas in like a more concrete way than just the abstract, like person-centered, trauma-informed. Like sometimes we hear those terms so much that we forget like the meaning behind those words. And I feel like you did a great job of really bringing that down to like, how does that look in a meeting with a person where you're doing a screening? And I really appreciated you doing that. So thank you so much.
Yeah, thanks for having me.
So, all right, you guys. Well, I hope everyone has a good rest of the day, and we look forward to seeing you at a future event. Thanks, everybody, for being here.
Bye.
Okay, bye.